just going to give you a very quick revision of what we studied yesterday before we move to our topic. So for yesterday, we were discussing about the anterior abdominal wall. So what anterior abdominal wall is? Can anyone tell me just a quick revision of what they can recall from yesterday's session? Any volunteer, please? Seher, would you like to try? Hina, Aram, I can see anyone can give it a try, please. Robina, I can see you here as well. Would you like to give it a try?
Okay, ma'am.
Yes, sure, please.
Ma'am, we have studied the 9 region of the abdominal cavity,
Hmm.
and we have studied the layers of the abdominal wall, that is fascia, superficial fascia, and deep fascia. Superficial fascia, also known as fascia of Kemper, and deep fascia, Scarpa's fascia, that is also continues with the deep fascia of the thigh, and it is also continues with the deep fascia of perineum. In the perineum, it is termed as Colles fascia. And we have studied the muscles of the abdominal wall,
Hmm.
that include muscles of the anterior wall, lateral wall, and the posterior wall. In anterior wall, we studied 2 main muscles, rectus abdominis muscle and pyramidalis muscle.
Hmm.
In the lateral abdominal wall, we have external oblique, internal oblique, and transversus abdominis muscle. And in posterior
Hmm.
wall, we have quadratus lumborum, psoas major muscle, psoas minor muscle, and iliacus muscle.
Hmm. Yes,
And
excellent. Anything else you can remember?
yes, ma'am.
Anything else?
Ma'am, the origin insertion of muscles we have
Hmm.
studied.
Yeah.
In rectus abdominis, we
Hmm.
studied that it is originated from the cartilages, fifth to seventh, almost 57 cartilage, and it is inserted on the pubic crest.
Hmm.
And its nerve supplies from T6 to T12, and
Hmm.
its function is flexion of the trunk.
Yes, excellent, brilliant.
And pyramidalis muscle is present in
Hmm.
20% of the population, and
Hmm.
it is originated from the pubic crest and pubic symphysis, and it is inserted on the linea alba,
Hmm.
and its nerve supply is subcostal nerve, and it
Hmm.
also tenses the linea alba.
Yeah, excellent.
And
And
we have studied
hmm.
external, yes, sir. External oblique muscle. It get origin from the lower ribs, lower 8 ribs, and it is inserted on the xiphoid process, linea alba, in the pubic crest, and the anterior 2/3 of the iliac crust. And its nerve supply is from lower 6 thoracic nerves, that is T7 to T12, and its function is that it flexes the trunk, and all of these muscles function is to protect the viscera as well.
Hmm.
And it has role in the formation of inguinal ligament as well, because inguinal ligament is formed from the um, condensation of the external oblique muscle aponeurosis.
Excellent.
And internal oblique muscle is originated from the anterior 2/3 of the iliac crust, and
Hmm.
it move in the upward direction, and it is inserted in the in the lower 6 costal cartilages on the linea alba and the pubic crest. And its
Yeah.
nerve supply is also from lower 6 thoracic nerves, that is T7A to T12.
212. Yeah. Brilliant.
And its function
What
is
about
also
transverse? Yeah, the same. The function is
transversus
same.
flexion.
Hmm.
Transversus abdominis has the origin from both from external oblique and internal oblique. It has origin from the anterior two-thirds of the iliac crust and from the lumbar fascia and also from the lower 6 costal cartilages. And it get inserted on the linea alba and the pubic crest. And its
Hmm.
nerve supply is also from the lower 6 thoracic nerves
Yeah.
and first lumbar nerve as well.
Yes.
And in the posterior wall, we have
Hmm.
quadratus lumborum muscle that
Hmm.
is originating from the posterior half of the iliac crust, and
Yes.
it is inserted on the lower border of 12th rib and first and second lumbar vertebra.
Hmm.
And its nerve supply is also from the T12 and L1 to L4, and its function is flexion of the vertebral column.
Hmm.
And we have psoas major muscle and minor muscle. Psoas major muscle has origin from the transverse process of the lumbar vertebra, and it is inserted on the lesser trochanter of the femur, and its nerve supply is L1 and L2. And psoas minor muscle, it is lying in front of the psoas major muscle, and it is originating from T12 and L1, and it is also in lying in front of the psoas major muscle and inserted on the iliopectineal eminence. And iliacus muscle is originating from the inner aspect of the iliac crust, and it is inserted along the psoas major muscle tendon. And whole of these muscle action is the flexion of the hip joint.
Flexion of the hip joint. Yeah. And also flexion of the
Vertebral column as well.
excellent. Excellent. Thank you so much, Ravina. You have brilliantly explained it really very well. And I'm so happy that you've revised it so well. I'm
Thank
really
you, ma'am. You
happy.
explained it very well. Thank you, ma'am.
Thank you so much. I really want all of you to be revising like Ravina every day so that you are just with us together and that we can immediately finish module wise. So today we are going to discuss the rectus sheath and along with its boundaries, the inguinal canal and what is its clinical importance. Then lastly, we'll be discussing about the femoral triangle and its clinical importance. So what rectus sheath basically is, it's an epineurotic sheath in front of the abdomen covering the rectus abdominis muscle. So basically, if you can see, this is whole forms the rectus sheath. Now, how does this rectus sheath form? It is formed anteriorly, the anterior wall of the rectus sheath. It is complete and it is held by tendinous insertions. Now, what are the tendinous insertions? We are going to look in the next slide. And posterior wall, it is incomplete, arcuate line, and it is free from the rectus muscle. So posteriorly, it is divided into above the arcuate line, below the arcuate line, and in between both of them. We are going to discuss it. Now, what happens if you look here? The rectus sheath, you can see the front part, the anterior part of the rectus sheath, while the posterior part is not visible of rectus sheath here. So if we divide the arcuate line or the costal margins is the boundary for us, like above, in between, and below that. So above the costal margin, we will find the aponeurosis of external oblique muscle, and posteriorly, the rectus sheath is deficient. Now, what happens when it comes in between the costal margins and the arcuate line? So anterior wall, it is formed by the aponeurosis of external oblique as well as the internal oblique muscle. While posteriorly, what happens? There is only the posterior lamina of internal oblique, and aponeurosis of transverse abdominis muscle. So now you can see the difference that above the costal margin, the posterior wall is deficient. But when it comes in between the costal margin and the arcuate line, the rectus sheath posteriorly is also present. And how it is formed? It is formed by the aponeurosis of transverse abdominis muscle and the posterior lamina of internal oblique muscle. Now what happens below the arcuate line? Now below the arcuate line, the anterior wall is formed by the aponeurosis of all the three muscles. What are the three muscles? The external oblique, internal oblique, and the transverse abdominis. But posteriorly, again, the wall is deficient, or there is no wall present posteriorly. So if you look at this drawing here with me, that above the arcuate line, and we are going to talk below the arcuate line. So above the arcuate line, we can see the external oblique muscle, the internal oblique muscle, they are all going through it. But posteriorly, when it comes, the rectus sheath, it becomes deficient here. Now, when we talk about below the arcuate line, you can see all the muscles present, internal oblique, external oblique, transverse abdominis, all the muscles are there. But when we talk about the posterior part of the rectus sheath, again, it is deficient here. So can anyone just revise for me that what happens above the costal margin, in between and below the arcuate line? Just a quick revision. Anyone? Fiba, would you like to try?
Ma'am, above the costal margin, anterior wall, it is the external aponeurosis of the external oblique muscle, while the posterior wall, it is deficit. Okay, and then between the costal margin and the arcuate line, we have both the anterior wall and posterior wall. Anterior wall is the aponeurosis of the external oblique and the internal oblique. Anterior internal oblique, and the posterior wall was the aponeurosis of the transverse abdominis and the posterior lamina of the internal oblique.
So you can remember posterior like this for easy.
Yes. Yeah.
Okay. And below the arcuate line?
Below posterior wall is deficit, and we have all the three muscles muscles anteriorly.
Yeah, and what are the three muscles?
External oblique, internal oblique, and transversus abdominis.
Yeah, excellent. Thank you so much.
Yeah.
Okay, so now coming to the contents of the rectus sheath. So rectus sheath contains everything. You can remember the formula of 2. For rectus sheath, we have the formula of 2, 2, 2. So 2 muscles will be there. That is rectus abdominis and pyramidalis, 2 arteries, superior and the inferior epigastric arteries. We have 2 veins, superior and inferior epigastric veins. So arteries and veins are similar. Superior and inferior epigastric arteries and superior and inferior epigastric veins. And we have 6 nerves. That is 5 lower costal intercostal nerves and 1 is the subcostal nerve. So just to remember or to memorize it, just a mnemonic, we can remember it like this, that 2, 2, 2 are the contents of rectus sheath. But the nerves will be 6. 5 lower intercostal nerves and 1 is the subcostal nerve. Now, what is the importance of rectus sheath? Why is rectus sheath really very important for us? Because it helps to maintain the strength of the anterior abdominal wall. And once we are trying to bend, it checks that we are able to bow properly. Especially when we are offering our pairs, we do bow down. So it is the work of the rectus muscle that helps us in bowing down. So if you can see here that it is supplied, this is the whole of the rectus sheath, and it has 2 arteries, superior epigastric artery, the inferior epigastric artery. And you can also see the nerve supply, that is the nerve branches of T7 to T12. That is lower 5 thoracic nerves and one is the subcostal nerve or T12 nerve. Now, what is the inguinal region? So inguinal region, it's basically an area of the abdominal wall which is extending from anterior superior iliac spine to the pubic tubercle. So if you look here with me in the diagram, you can see that this is the anterior superior iliac spine and it is going up to the pubic tubercle. So this distance in between or this area is completely called as the inguinal region. And we are going to study this region of inguinal region, and it includes the inguinal canal is found here. And in the inguinal canal, we have the contents, like we have the contents for the rectus sheath. So what is, first of all, what is inguinal ligament? Another name for inguinal ligament, it is also known as ligament of Poppard. It starts from the anterior superior iliac spine to the pubic tubercle. If you can see here, the arrow that is marked, it starts from anterior superior iliac spine, extending up to the pubic tubercle. So this hole is known as the inguinal ligament. And how is inguinal ligament formed? It is formed by the aponeurosis of external oblique muscle. And if you see here with me that it is attached, the inguinal ligament, it is medially attached to the pubic tubercle. And this inguinal ligament, it is forming the floor of the inguinal canal, because inside lies the inguinal canal that we are going to study just now. So inguinal ligament, I'll just quickly revise what inguinal ligament is. Inguinal ligament, it's a part of an inguinal region which is extending from the anterior superior iliac spine to the pubic tubercle. It is formed by the aponeurosis of external oblique muscle. Medially, this ligament, inguinal ligament, it is attached to the pubic tubercle, and below, or it forms the floor or the inferior wall of the inguinal canal. Now, what inguinal canal is? Now, inguinal canal, it's a musculo-aponeurotic canal. It's a musculo-aponeurotic tunnel which is extending from the deep inguinal ring to the superficial inguinal ring. So if you look here, that this is the deep inguinal ring and this is the superficial inguinal ring. So in between, if we can suppose that this is the deep inguinal ring and this is the superficial inguinal ring. So the distance in between both of them is called as the inguinal canal. So this whole space is known as the inguinal canal. Above is deep inguinal ring and below is the superficial inguinal ring. So it is present above and in parallel with the medial half of the inguinal ligament. So if we see, this is the anterior superior iliac spine and this is the pubic tubercle. So it is in parallel with the inguinal canal and it is in the medial half of the inguinal ligament. It is not covering whole of the inguinal ligament. It is just half of it. And what is the length of the inguinal canal? It is measuring about 4 centimeter in length. This was one of the very recall question when it came in it came in 2012 asking that what is the length of the inguinal canal. So the correct answer is it is going to be 4 centimeter in length. Now what is the direction of the inguinal canal? If you look here, it is the deep inguinal ring and this is the superficial inguinal ring, a very small 4 centimeter. So it is directed downward and medially towards the pubic tubercle and forward as well. In the female, this space is really very narrow, and because it's very narrow, so the chances of having inguinal hernia are very less in females as compared to the male. And if you look here in this diagram, it is coming from the back side. It is coming from the posteriorly, that this is the anterior superior iliac spine and the pubic tubercle. So posteriorly we have the inguinal, so deep inguinal ring, and we have the superficial inguinal ring. In between, the space is called as the inguinal canal. Am I clear till here? Or do you want me to repeat anything for you? All right. Thank you so much, Dr. iPhone, for acknowledging that. Yeah. So it's one of the another diagram that I've taken just to make it more clear that this is the inguinal ligament and this is the superficial inguinal ring, that is, and we have the deep inguinal ring above here. So in between, the distance is called as the inguinal canal, extending from deep inguinal ring up to the superficial inguinal ring, and it is going downward, forward, and medially towards the pubic tubercle. Again, you can see here in this diagram that this is the deep inguinal ring. This is the inguinal ligament, which is going the blue color. And this is the superficial inguinal ring. So in between the space, this space is known as the inguinal canal. Now, what is deep inguinal ring? It's an oval shaped hole in the fascia transversalis. Now, what is fascia transversalis? It is the fascia which is covering the transverse abdominis muscle. That is known as fascia transversalis. And it is, you can also say it is the midpoint of the inguinal ligament. Because when we see the inguinal ligament, this whole area of inguinal ligament is not known as inguinal canal. The mid portion that begins in between from here is the area of the inguinal canal. So this distance between is the deep superficial deep inguinal ring, and this one is the superficial inguinal ring. So in between, the space is known as the inguinal canal, and it is measuring 4 centimeter in length. Or we can also say it is the midway in between anterior superior iliac spine and pubic symphysis. And in the relation of the inguinal canal, deep inguinal ring, in the medial relation, it has inferior epigastric vessels. Now, if you look here with me, the inferior epigastric vessels are there. If you look here, that inferiorly, the vessels are going down here. This side is known in the medial relationship of the deep inguinal ring. These vessels, they form the medial relationship. And now, what is the importance of the deep inguinal ring? It gives rise to the internal spermatic fascia, or the internal covering of the round ligament of uterus. So it's very important because it is forming the internal spermatic fascia in males, and in female, it is providing the cover to the round ligament of uterus. And what is the length? And it is deep inguinal ring. It is 1.26 centimeter above the femoral artery. So for the deep inguinal ring, I'm just going to quickly revise it, that it's an oval shaped hole or a defect in the fascia transversalis, and it can also be located by its the midpoint of the inguinal ligament, or it is in midway between anterior superior iliac spine and pubic symphysis. And the importance of this deep inguinal ring is that in the males, it forms the internal spermatic fascia, and in the female, it forms the internal covering of the round ligament of uterus. It's in the medial relationship of deep inguinal ring is the inferior epigastric vessels, and the inguinal ring itself, it is 1.26 centimeter or 1.26 centimeter above the femoral artery. So if you look at here with me, this is the femoral artery, and this inguinal ring canal or the deep inguinal ring, it is above this. So this is the relationship. That is why it is said The deep inguinal ring is above the femoral artery. Now, what is superficial inguinal ring? So superficial inguinal ring, it's a ring which is V in shape, while the deep inguinal ring, it was oval shape. Now, superficial inguinal ring, it is a defect in the external oblique muscle aponeurosis, and it is formed, its base is formed by the pubic crust, and it gives rise to external spermatic fascia. While if you remember, the deep inguinal ring, it is a defect in the transversus fascia, muscle of the transversus fascia, and it was giving rise, and it was giving rise to the internal spermatic fascia as well as the fascia covering the round ligament of the uterus. But the superficial inguinal ring, it is only giving rise to the external spermatic fascia. That means it has a role, more important role in males, and it lies above and medial to the pubic tubercle, while it lies, the deep inguinal ring, it is above the femoral artery. This is the main. So if you can hear me, a superficial inguinal ring, it is V in shape, while deep inguinal ring, it was oval in shape. The superficial inguinal ring, it is formed as a defect in the external oblique muscle aponeurosis, while the deep inguinal ring is a defect in the fascia transversalis. Now, superficial inguinal ring, it gives rise to the external spermatic fascia, while deep inguinal ring, it gives rise to the internal spermatic fascia in cases of male, and in the female, it forms the covering of the round ligament of uterus. And the superficial inguinal ring, it lies above. If you can see here in this, it lies above and medial to the pubic tubercle. While the deep inguinal ring, it lies above the femoral artery. So if you look here with the superficial femoral ring, it lies medial because the pubic tubercle is lying here. So that is why it is in medial in relationship to the pubic tubercle. Or we can see that the pubic tubercle This is whole is going to be the pubic tubercle, and it is in relationship medially to the pubic tubercle, this superficial inguinal ring. So can anyone just quickly tell us the differentiating points between deep and the superficial inguinal ring?
Ma'am, can I?
Yeah, sure, Fiba. Yeah, definitely.
Yeah, the superficial inguinal ring is V in shape, while the deep inguinal ring is oval in shape. The superficial inguinal ring, it is mainly a defect in the external oblique aponeurosis, while the deep is a defect in the transversalis fascia. It mainly, the deep inguinal ring mainly forms the midpoint of the inguinal ligament, or between the anterior superior iliac spine and the pubic symphysis. And the deep inguinal ring, it mainly gives rise to the internal spermatic fascia, or the internal covering of the round ligament of the uterus, while the superficial inguinal ring gives rise to the external spermatic fascia. And the deep inguinal ring lies like 1.26 centimeter above the femoral artery, while superficial inguinal ring lies above and medial to the pubic tubercle.
Yes, excellent, Fiba. Thank you so much. You really explained. You really just revised it really very well to us, all of you. Thank you so much for that.
Thank you, ma'am.
So now we are going to study what are the relationships of the inguinal canal. So inguinal canal, as it is a canal, so it will be having 4 relationships. If as this is the deep inguinal ring, and this is the superficial inguinal ring. In between, we have the inguinal canal. So inguinal canal, it has an anterior wall, it has a posterior wall, it has a roof, and it has a floor. So the anterior wall of the inguinal canal, because this is the deep inguinal ring, and deep inguinal ring, so it is the aponeurosis of the external oblique muscle, and it is reinforced by the internal oblique muscle. So this anterior wall, it's an aponeurosis of external oblique, and it is reinforced by the internal oblique muscle. While when we talk about the posterior wall, it is formed by the fascia transversalis, and it is medially, it is reinforced by the conjoined tendon. That is, the strength is given medially by the conjoined tendon. The floor is formed by the inguinal ligament, because inguinal ligament is here. And if you look here, this is going to be the pubic tubercle, will be here, lying here. And the roof is formed by the same muscle, that is the external oblique and the transverse abdominis muscle. So it's very easy to remember. If you look at the diagram here, we have the diagram here. That the inguinal canal, it is formed superficially, or it is formed above by the internal oblique and the transverse abdominis. And below, it is formed by the inguinal ligament. This whole of the inguinal canal, it is below is the inguinal ligament. And on the anterior side, it is formed by the aponeurosis of external oblique and internal oblique muscle. Posteriorly, we have the conjoined tendon, we have the transversus fascia, and medially, the strength is given by the conjoined tendon. Now, what are the contents of the inguinal canal? So for the rectus sheath, I told you the formula of rule of 2. That was 2, 2, 2. Now for the inguinal canal, we have the formula of rule of 3, 3, 3. Now what happens in the case of females in inguinal canal, everything is going to be similar in male and female, except in the female, we are going to have round ligament of uterus in females, and in the male, we are going to have the spermatic cord. Otherwise, we have 3 arteries, we have 3 nerves, and we have 3 other structures in case of inguinal canal. That is rule of 3. For rectus sheath, we had rule of 2. So 3 arteries. What are the 3 arteries? The first one is the testicular artery. The second one is the cremasteric artery. And the third one is the artery of vas deferens or ductus deferens. These are the 3 arteries. Now coming to the 3 nerves, we have ilioinguinal nerve, we have cremasteric nerve, and we have the sympathetic nerves, sympathetic nerve fibers. So we have 3 nerves, that is ilioinguinal nerve, the cremasteric nerve, and the sympathetic nerve. We have 3 nerves. Now what are the other 3 structures? We have the number 1 is the vas deferens or the ductus deferens, and secondly we have pamponiferum venous plexus, and the third we have the lymphatic vessels. So rule of 3. 3 arteries, 3 nerves, and 3 other structures. In the female, the added thing is going to be the round ligament of uterus. In the male, it is going to be spermatic cord. So just for remembrance, we can make it easy. Rule of 2 and rule of 3. So can anyone just say, give us a quick revision of rule of 2, please? Hina, would you like to give a try, please? Anyone can try it, please. No one would like to try?
Ma'am, the 2 muscles, rectus abdominis and the pyramidalis. 2 arteries, superior and inferior epigastric arteries. 2 veins, superior and inferior epigastric veins. And we have the 6 nerves, which was the 5 lower intercostal and the subcostal nerves. Lower intercostal was from T7 to T11, and the subcostal was T12.
Yeah. Or you can easily say T7 to T12. Just.
Okay.
Okay. And what's the rule of 3 for inguinal canal?
For the inguinal canal, in the females, we have the round ligament of the uterus, while in the male, what we include is the spermatic cord. 3 arteries, where the testicular artery, cremasteric artery, and the artery of ductus deferens. The nerves were ilioinguinal nerve, cremasteric nerve, and the sympathetic nerve. And the other structures were vas deferens, pampiniform plexus, and the lymphatics.
Excellent.
Vessels, yeah.
Thank you so much. You really explained this. Yeah, just a very quick revision from you. Thank you so much, Fiba.
Welcome.
Now, what is the spermatic cord and what are the layers of the spermatic cord? So there are 3 layers of the spermatic cord. All of them, they are derived from the structures in the abdominal wall. So external spermatic fascia, if you look here, this is whole is the spermatic cord, and these are the 3 layers of the external spermatic sperm cord. So we have the external spermatic fascia, we have the cremasteric fascia, and we have the internal spermatic fascia. So the external spermatic fascia, we already discussed, it is formed by the external oblique muscle. So external and external are easy to remember. Then we have the cremasteric fascia or the cremasteric muscle, which is formed by the internal oblique muscle. And lastly, we have the internal spermatic fascia. So internal spermatic fascia, it is formed by the transversalis fascia. Now, what is the importance of these 3 layers? These coverings, they result from testes descending from the posterior abdominal wall to the scrotum during embryological development. So these are the 3 layers that it prevents from getting it down into the scrotum during the embryological life, or when the baby is in the fetus. In the fetus period, it prevents the descending of down from reaching it downwards. So We have 3 layers for the spermatic cord. The external spermatic fascia, starting from outside, we have external spermatic fascia, which is formed by the external oblique muscle. In between, we have the internal premastric fascia, which is formed by the internal oblique muscle. Then we have the internal spermatic fascia, which is formed by the transversalis fascia. So please don't get confused with it, that internal spermatic fascia will be formed by internal oblique muscle. No, never. It's going to be formed by the transversalis fascia. Because in 2015, there was a question asking that how is the internal spermatic fascia formed? So in internal spermatic fascia, it is formed by the transversalis fascia muscle, not by the internal oblique muscle. Because all the options were there in the question. Internal oblique muscle, external oblique muscle, transversalis fascia. So your correct answer will be transversalis fascia. Am I clear till here? Anything needs to be repeated? Okay. Okay, thank you, Dr. Aifun, for acknowledging. So now, next we have is the conjoined tendon. So conjoined tendon, what is the conjoined tendon? So if you look here in the diagram, it's a very small tendon which is formed by the joining of both the lowest tendinous fibers of the internal oblique and the transverse abdominis muscle. So both the muscles are coming. If you look here, the internal oblique muscle and the transverse abdominis muscle, when they both muscles are coinciding with each other, it forms a tendon. In together, this tendon is called as a conjoined tendon. Now it is fixed to the pubic crust and the pectineal line, and medially is the linea alba. So this in between medial part is the linea alba, and it is fixed to the pectineal line. This is the pectineal line and the pubic crust here. If you look at here, this is the pubic crust. So the fixed part is the linea alba. The fixed part is the pubic crust and the pectineal line that is fixed, and medially is the linea alba. However, laterally it does not have anything. So laterally it is free. It has a free border. Because if you look here, the lateral border is free. It has nothing to do. So conjoined tendon, it's basically a tendon which is formed by the fibers, lowermost fibers of the internal oblique and transverse muscle. Now we have a Heisenberg triangle. So what is Heisenberg triangle? So if you look here, it's a very clear and a very easy diagram to understand. That this is the deep inguinal ring. This is the superficial inguinal ring. The content is the spermatic cord that is coming down from the inguinal canal, and in between the space is called as the inguinal canal. And the inguinal canal has a space which is known as the Heisenberg triangle, or the another name for this triangle is, can anyone tell me the another name for this triangle? If you can remember. No one? This triangle, it's the alternative name, or the another name for this triangle is medial inguinal fossa. So it's a region which is very near to the inguinal canal, and it is also known as the medial inguinal fossa. Now, what are the boundaries of this Heisenberg or the medial inguinal triangle? boundaries. So if we look here in this diagram, you can see very easily a very beautiful diagram. This is that laterally we have the inferior epigastric vessels or the inferior epigastric artery. This is comes in the lateral region, and the base, because this is an inguinal canal and this is the ligament. So this inguinal ligament, it forms the base of the triangle. So in the triangle we have only 3 boundaries. We don't have 4 boundaries in the triangle, because triangle is always a 3 shape structure. So we have 3 things here. And when we talk about the medially, we have the lateral border of the rectus abdominis muscle. So to remember easily, we can just remember that it is the part towards the median of the inguinal fossa, and the lateral boundary is formed by the inferior epigastric artery. The medial one is formed by the lateral border of the rectus abdominis muscle, and in the base we have the inguinal ligament. Now, what is the importance of this Heisenberg triangle? Why am I discussing here? Because it's a very important site for the direct inguinal hernia. Most of the direct inguinal hernia, they occur at this place. That is why we have to know about the boundaries and the location of this triangle, Heisenberg triangle. So what is hernia? An hernia is the protrusion of an organ through the wall of the compartment that contains it. So we have 2 types of hernia. We have direct inguinal hernia and we have the indirect inguinal hernia. Can anyone recall what is the difference between direct and indirect inguinal hernia? Okay, I'm going to tell you, and then anyone would like to repeat it for me. So we have direct inguinal hernia, we have indirect inguinal hernia. So direct inguinal hernia, it's acquired during the lifetime, while indirect inguinal hernia, it's a congenital hernia. Now, direct inguinal hernia, it occurs at the level of the superficial inguinal ring, that is, it occurs below, while indirect inguinal hernia, it occurs at the level of deep inguinal ring, or it is the area in embryologically part we can call it as processus vaginalis. And it usually happens, this indirect inguinal hernia, it occurs in young males. Now, direct inguinal hernia, it happens medial to the inferior epigastric vessel, while indirect inguinal hernia, it happens lateral to the inferior epigastric vessel, and it transverses the inguinal canal, and it can enter the scrotum via the superficial inguinal ring. And the direct inguinal hernia, the sac is limited by peritoneum and the transversus fascia. For the indirect inguinal hernia, it is limited, or it is persistent, it is limited by the presence of processus vaginalis at the level of deep inguinal ring. Now, direct inguinal hernia, it does not usually enter the scrotum, while indirect inguinal hernia, it enters the scrotum, but via superficial inguinal ring. And which is more common, the direct or the indirect inguinal hernia? So just for our remembrance, indirect inguinal hernia is more common as compared to the direct inguinal hernia. Is it clear till here, the differences between direct and indirect inguinal hernia? Yes, Dr. iPhone, can you please unmute yourself and just quickly revise for us the differences between direct and indirect inguinal hernia?
Yes, direct inguinal hernia that occurs from superficial ring, and indirect that occurs from deep ring. Direct is not usually common among old ages, and indirect is congenital and occurs from younger ages. And direct is usually does not, and direct hernia does not usually enter in scrotum. and indirect usually means entrance in scrotum. It is
Yes.
more common. Indirect is more common than direct.
Hmm.
Yes.
Yeah. And what is the relationship with the inferior
Relationship.
epigastric vessels?
It is indirect lies lateral to inferior epigastric vessels,
Yeah.
transversus canal, and can enter the scrotum by
Hmm.
superficial ring.
Yes. And what about direct inguinal hernia?
It leaves leaves abdomen medial to inferior epigastric vessels.
Yes. Yeah. So direct inguinal hernia is medial or indirect is lateral.
Yes.
Yeah. Thank you so much. May I know your
Welcome.
good name?
And Dr. Sana.
Sir. Okay. Thank you
Thank
so
you.
much. No problem.
Welcome.
Yeah, so Sana really very well told us the differences between direct and indirect inguinal hernia. So I hope till here the inguinal part of the inguinal canal, the importance of an inguinal canal, the differences between direct and indirect inguinal hernia is clear to all of you. Because now I'm going to move to the femoral triangle, a very important topic in relation with the exam, because we have very frequent questions from this part of the sessions, that is inguinal canal and femoral triangle. Both are really very important from the exam point of view. So another name for femoral triangle is the Scarpa triangle. So if you look here, now where it is formed, as the name says, it's a femoral triangle. So it's going to be having a medial border, a lateral border, a base, and an apex. It has 4 things. So it's a triangular area on the front of the upper 1/3 of the thigh. If you look here, this is the thigh, upper 1/3 of the thigh, and it is below. This is the inguinal ligament, and this area below the inguinal ligament is known as the femoral triangle. And this hole is a part of a thigh. So this area in between is known as the femoral triangle. Now to explain the boundaries, it's very easy. So if we look here, I've just made a very mnemonic for you guys to remember it very easily. The mnemonic is SAIL. So laterally, we have the sartorius muscle. Medially, we have the adductor longus, that is A stands for adductor longus, I stands for inguinal ligament, L stands for the inguinal ligament. So again, I'm going to repeat this mnemonic for easy memorization. That's SAIL. SAIL is the mnemonic to remember the boundaries of femoral triangle. S stands for sartorius, which forms the lateral boundary of the triangle. And medially, we have the adductor longus muscle, the medial border of the adductor longus muscle, that is A. And superiorly, or that is formation of the base, it is formed by the inguinal ligament. So if you remember this SAIL, so till now we have studied 3 mnemonics or 3 ways in order to just easy for remembrance. Rule of 2 for the rectus sheath, rule of 3 for inguinal canal, and we have for femoral triangle, we have the mnemonic of SAIL. Now, how is the roof of the femoral triangle? It is formed. It is formed by the skin. It is formed by the superficial fascia, which is containing superficial inguinal lymph nodes along with lymphatics. We have the femoral branch of the genitofemoral nerve. We have branches of ilioinguinal nerve. We have superficial branches of femoral artery along with its accompanying vein. So for easy remembrance, femoral artery, femoral branch of femoral nerve, genitofemoral nerve, and branches of ilioinguinal nerve. We have a part of greater saphenous nerve. So if you look here, you can all you can also try to palpate your inguinal ligament. So it's the anterior superior iliac spine to the pubic tubercle. This area, it will be known as the inguinal ligament, and just below this is the femoral triangle. And what it contains superficial inguinal lymph nodes along with its lymphatic, femoral branch of genitofemoral nerve, branches of ilioinguinal nerve, femoral artery, superficial branches of femoral artery with its accompanying vein, and we have the upper part of great saphenous vein. We also have a deep fascia with saphenous opening and covering, which forms the cribriform fascia. So if you look here in this triangle, this is the femoral triangle. It contains the superficial inguinal lymph nodes. It has the branches of the ilioinguinal nerve, the femoral branch of the genitofemoral nerve, and superficial branches of the femoral artery and its veins. They both are also present here. And this is the great saphenous vein. And the upper part of this great saphenous vein is the content of the roof of the femoral triangle. Now, how is the floor formed? This floor, what do I mean by the floor? This part is known as the floor, this whole area is known as the floor. So in the floor, we have 4 muscles. So in the exam, there was a question in 2016. All the muscles name were there, and they ask you from lateral to medial. Now here I have put the name of the muscles from medial to lateral. That is, the first muscle is the adductor longus. Then we have the pectineus muscle. Then we have the tendon of psoas major muscle and iliacus muscle. But in the exam in 2016, the question was asked from lateral to medial. So if it is going to ask from the lateral, the first muscle will be iliacus. Second will be tendon of psoas major muscle. Then we have pectineus muscle and the adductor longus muscle. And what it resembles to? It resembles to a gutter which is loaded with fat, the profunda femoris artery and its medial circumflex branch. These are all the branches of the femoral artery, which we are going to study in our next upcoming sessions, few sessions. Now, what are the contents of femoral triangle? So femoral triangle, it contains femoral artery and its branches, femoral vein and its tributaries, the femoral sheath, and the nerves. So what are the nerves included in it? Femoral triangle, we have the femoral nerve, we have the femoral branch of the genitofemoral nerve, we have nerve to pectineus muscle, we have the lateral cutaneous nerve of the thigh, and the lymph nodes, the deep inguinal lymph nodes. These are all the contents of the femoral triangle. So for easy remembrance, we can remember the name is femoral triangle. So it has all things related with femoral artery, femoral vein, femoral nerve, femoral sheath, the deep inguinal nerves, and along with that some extra nerves, that is like nerve to the pectineus muscle, lateral cutaneous nerve of the thigh, and nerve femoral branch of the genitofemoral nerve. Am I clear till here? Can anyone repeat for me the contents and the boundaries of femoral triangle? Anyone would like to give just a quick revision for us, please, all of us? The boundaries of femoral triangle and the content of femoral triangle. Fiba, would you like to give it a try, please?
Yeah, sure, ma'am. Ma'am, the femoral triangle, the boundaries are the mnemonic sail, laterally the sartorius muscle, medially by the adductor longus. Base was formed by the inguinal ligament, and the apex by both the medial and the lateral borders. The contents of and even the roof and the floor. Roof, mainly we have the skin, superficial fascia, and the deep fascia. The superficial fascia mainly contains the superficial inguinal lymph nodes, the femoral branch of the genitofemoral nerve, branches of the ilioinguinal nerve, and the superficial branches of femoral artery and the veins, and the upper part of the saphenous vein. The deep fascia has the saphenous and the cribriform fascia. While the floor is mainly formed by four muscles. If we call from the medial to the lateral, it will be the adductor longus, pectineus, the psoas major, and the iliacus muscle.
Excellent.
And okay, and then we have the contents. The contents include the femoral artery and its branches, the femoral vein, the femoral nerve. Then we have the femoral nerve and the deep inguinal lymph nodes. The other nerves which were included were the pectineus nerve, femoral branch of the genitofemoral nerve, and the lateral cutaneous nerve of the thigh.
Yes, excellent. Thank you so much, Fiba. So let's move ahead. Now, what is femoral sheath? So femoral sheath, it's a part of a femoral triangle. Now, the first important thing that you need to know that femoral sheath, it is 1 inch or 2.5 centimeter above the inguinal ligament. So if you look here, so this is the inguinal ligament we have, and the area above it will be, the area below the inguinal ligament, because this is the inguinal ligament, and the area below this is known as the femoral sheath. It is 1.5, 1 inch or 2.5 centimeter below the inguinal ligament. Now, how it is formed? It's a funnel-shaped sleeve enclosing the upper 1.5 inch from the vessel. It is formed by the downward extension of the abdominal fascia. So it's nothing extra. It's just the extension of the abdominal fascia that we have. Now, the anterior wall of this femoral sheath, it is formed by the fascia transversalis, and the posterior wall is formed by the fascia iliaca. Now, what is the shape of this triangle? It is funnel in shape. You can see that it's a funnel in shape, and the lateral wall is vertical. Its lateral wall is vertical, while the medial wall is oblique in direction, and both of them, they are meeting downwards medially at a point. Now, what does this femoral sheath contain? It contains three things. So first, it contains the femoral canal. We have the femoral artery and the femoral vein. We have three things into it, into the femoral sheath. The first, it is divided into three compartments by two vertical septas. So if you look, this whole is the femoral sheath, and it has three contents into it. One of the content is the femoral canal. The other one is the femoral artery, and we have in the middle is the femoral vein. So if we look in the direction, if we talk about it, that femoral canal is medially, femoral vein, it is intermediate, and femoral artery, it is the most lateral part of the femoral sheath. Because lateral is the arterial compartment, it contains the femoral artery and also the branches of the genitofemoral nerve. In the intermediate compartment or the venous compartment, this is the femoral vein, and medially, it is the femoral canal. Now, what is femoral canal? It's a small area. It's a small conical area. It's an entrance. It's a, let me take my pointer. So basically, it's an entrance. This part is the femoral canal, and it is the entrance for the femoral canal. From here, the whole of the femoral canal will go down, because the content other than this are the femoral vein and the femoral artery. Now the shape of this femoral canal, it is oval in shape like the deep inguinal ring. And this femoral canal, it is big in female as compared to the males. Now, what are the contents of this femoral canal? So this femoral canal, it contains lymph node, that is the lymph node of cloacaid, and also the lymph, or we can call it the lymph nodes of Rosenmiller, is some other lymphatics, and a small amount of areolar tissue. And what do I mean by the lymph node of cloacaid? It means that it is the lymph node of the clitoris, which is draining here. And this femoral canal, it's a potential space and a very weakened site which can lead to femoral hernia. So I will quickly revise the content of this femoral canal. Just to memorize, I have there's a mnemonic for this femoral canal that is known as VAN. That is from medially. Medially we have the vein. If you look medially in the femoral canal, specifically I'm talking, we have the vein. In the intermediate, in the artery is in the middle, and the nerve, femoral nerve, is the lateral part of the femoral canal. If we are talking just about the femoral canal in relationships, so vein will be the most medial, artery will be in the middle compartment, and the nerve will be the most lateral. So as Fiba just told us about the femoral triangle and its content, so I'm just quickly going to revise what femoral sheath is. So femoral sheath, it's basically it's 1 inch or 2.5 centimeter area below the inguinal ligament, and it is formed by the downward extension of the abdominal fascia. The anterior wall of the sheath, it is formed by fascia transversalis, and the posterior wall is formed by the fascia iliaca. The shape of this femoral sheath, it is funnel in shape. The lateral wall is vertical, the medial wall is oblique, and both of them are meeting downwards. It is divided into 3 compartments. The 3 compartments are the lateral compartment, which will include the artery. The medial compartment will include the vein, and the intermediate compartment will include the vein, and the medial compartment will include the femoral canal. So remember that the medial compartment of femoral sheath is femoral canal, and femoral canal has 3 contents into it. The most medial will be the femoral vein, then we have the artery in the between, and the nerve most laterally. Now what does this femoral canal contain? It contains lymph node, that is the lymph nodes of cloacaid, which is draining the clitoris, a small amount of areolar tissue, and this femoral canal, it is the site from which the femoral hernia can happen. The importance of this femoral canal is that it's a site or it's a weakened area from which femoral hernia can happen. Am I clear till here?
Ma'am, that the last mnemonic which you had given, that femoral vein, artery, and nerve, that is in the femoral canal. It is in the medial compartment. I have a doubt. I didn't understand that last.
Yeah. Okay. So, Fiba, if you look here. Okay. So this is the femoral canal. So on the medial side, we have the vein. In the intermediate or the middle part, we have the artery, and on the medial side of this femoral canal will be the nerve. So this mnemonic is basically for the femoral canal.
Okay, ma'am. Thank you. I get it now.
Okay, thank you so much.
Bye.
Okay, so now I'm going to take the questions. Who's going to take my first question? I want all of you to be actively participating. Who's going to take the first question?
Ma'am, you can
Okay,
start.
yeah, Fiba, yeah, please, I'll go ahead.
A 26-year-old female presents with right iliac fossa pain. Okay. And is taken to a theater for appendectomy. An incision is made through the skin and onto muscles with fibers passing inferiorly in an oblique direction. Which abdominal muscle does this describe? Inferiorly, I think it is external oblique. Inferior.
Excellent. Excellent. Yeah, the correct answer is external oblique. How did you make us? Can you explain to us?
Ma'am, I remember it as like from the inferior and oblique is always external. I always remember
Yeah,
that way.
yes, exactly. Yeah, I always remember it like this also. That the fibers which are going in an inferior and in oblique directions are always the external oblique muscle.
بتفهم ايميلين قلت له سوري اني بعطي ايميلين بس انت مشكلتك انها بالاخر بعدين انتبهت شو هي مشكلته هو مش عامل انكلود للنون يو ام.
So Fiba, would you like to take the next question also?
Okay, ma'am.
Okay.
Doctor, someone wants to answer. Dr. iPhone, she wants to volunteer.
Yeah, sure. I have so many questions. No problem. I have so many questions. Everyone is going to get a chance. No one is going to be left.
Okay, ma'am, this is a question. Okay. During an operation, a midline incision was made at an anatomic location 2 centimeters below the umbilicus. Which of the following list in order the layers of the anterior abdominal wall as they would be incised and separated? Okay, skin, subcutaneous fat, superficial fascia, deep fascia, facial muscles, anterior rectus sheath, rectus muscle, a deep facial muscle cover. Ma'am, it's too much to read. Can I just find out what is
take
the
your
best?
time. No, you can read. So everyone is going to. I want everyone to be answering for me in the chat box. Apart from Fiba. All of you are going to answer for me in the chat box.
Facial skin.
Yeah, read it loud so that everyone can hear you.
Skin, skin, subcutaneous fat. No, the superficial fascia, deep fascia, facial muscles. That is the anterior rectus sheath, rectus muscle, a deep facial muscle cover, posterior rectus sheath, peritoneal fat, and peritoneum. Okay, pre-peritoneal fat and peritoneum. Option B, skin, subcutaneous fat, superficial fascia, deep fascia, facial muscles covering anterior abdominal wall. It's okay. Transverse abdominal muscles, a deep facial muscle cover, posterior rectus sheath, pre-peritoneal fat, and peritoneum. Skin, subcutaneous fat, superficial fascia, deep fascia, facial muscle, muscle cover, anterior rectus sheath, rectus muscle, a deep muscle cover, peritoneum and pre-peritoneal fat. No. Skin, subcutaneous fat, superficial fascia, deep fascia, facial muscle cover, anterior rectus sheath, rectus muscle, deep facial muscle cover, posterior rectus sheath, pre-peritoneal fat, and peritoneum. I think the answer is transversal fascia, peritoneum.
So let's exclude the option first. People, let's exclude the option first. Which one is wrong? So that it's easy for you to choose in between 2 options or 3 options.
That's covering, okay. I think option C is not an answer for sure.
Yes, option C is cancelled.
Okay.
What do you think about D?
In superficial fascia, deep fascia, facial muscles. cover rectus sheath. It almost looks like the same. Let me just.
No.
No, I think that is wrong. No, it's wrong. It's wrong. Yeah,
Yeah,
it's wrong.
D is also wrong. Yeah. So C and
yeah, campus, and then we have the scarpas.
Yes,
Okay.
exactly. So these both options C and D are excluded. Now the confusion is between A and B.
Okay.
So let's come to option B first.
Okay. Option B. Skin is there. Subcutaneous fat is there. Superficial fascia. I think the answer should be campus fascia. Has to be. I think A is the answer. A is the answer.
Yeah, exactly. A is the correct answer. Why not B?
Because it is campus fascia first, and then we have the scarpas fascia.
Scarpa fascia. Yeah, it looks to be a very difficult question, but it's a very simple question.
Yeah,
because we have already
Okay,
yes, Rubina, Noorpur, Dr. Zaif, Sana, everyone is correct in the chat box. And also it has the transversus abdominis muscle if you look at the option B. Because we have the rectus muscle that we cut during our cesarean section.
Yes, ma'am.
Okay. Thank you, Fiva.
Yeah. You're welcome, ma'am.
Okay. So Sana, would you like to take the next one?
Yes.
Yeah. So it goes for you here.
Which of the following characteristic about rectus sheath is correct? Below the arcuate line, the posterior layer of the rectus sheath is formed by the transversalis fascia. Each rectus abdominis muscle is attached by a single tendon to the pubic bone. Below the arcuate line, the posterior wall of the sheath is formed by internal oblique. All of the above and none of the above. So which of the following characteristics about rectus sheath is correct? Posterior layer of the rectus sheath is formed by the transversalis fascia. A is correct. Each rectus abdominis muscle is attached by a single tendon to the pubic bone. It is also correct, I think. Inguinal ligament, maybe. Each rectus abdominis muscle is attached by a single tendon. So single tendon बनता है वो. Below the rectus arcuate line, the posterior wall of the sheath is formed by internal oblique. Below arcuate line, posterior wall of the sheath is formed by internal oblique. A, I think A is the answer.
Okay. Why A?
Because A is correct. बाकियों में doubt है.
क्या doubt है?
Each rectus abdominis muscle is attached by a single tendon to the pubic bone. They're talking about single tendon.
So it's wrong.
So it's single tendon. Yes.
Yeah, it's wrong. And C?
See, below the arcuate line, the posterior wall of the sheath is formed by internal oblique. So posterior wall of the sheath is formed by, not formed by internal oblique.
So it is formed by which?
It is formed by sheath.
Let me take you back
Internal
where we
oblique.
studied. That we
Internal
studied. Below the arcuate line.
Aponeurosis of all three muscles, yes. I was thinking about a single muscle. I was recalling that. But yes, all three muscles.
So what is going to be now your correct answer?
Correct answer is A.
How come A? Now explain all of us that why A?
Because which of the following characteristic about rectus sheath is correct? They're asking about the correct option. So below the arcuate line, the posterior wall of the rectus sheath is formed by, okay, yes, you're right. None of the above is the right answer.
Exactly. Now explain to us that why.
Because below the arcuate line, I just saw the slide you showed that it is formed by all muscles, all three, fascia of all three muscles.
Yeah. So this option is incorrect. Wrong.
Yes, it is wrong. Each rectus abdominis muscle is attached by a single tendon to the pubic bone. No, it is not attached to the pubic bone, first of all. It is attached to the tubercle.
Yeah,
pubic tubercle.
Yeah, exactly. And C?
Below the arcuate line, the posterior wall of the sheath is formed by, no, it's not formed by internal oblique. It is formed by the fascia 3 muscles.
So the correct option is?
None of the above.
Yeah, excellent. The correct answer is none of the above. But why? I'll tell you. Sana, just a small thing that if you look here again with me in this. Look, I told you below the arcuate line, the anterior wall is formed by the aponeurosis of 3 muscles. The
All
posterior
muscles,
wall
yes.
posterior wall is not there below the
Yeah,
arcuate
yes.
line.
Oh, yes,
So
yes.
so your answer is right, but just to correct the explanation to make it easier for you
I
to
got it.
yeah.
I got
Now
it.
got it? Yes, and
Yes.
Tiba, yeah, you're excellent. You're right in the chat box. I can see. I want all of you to be answering in the chat box. So Sana, would you like to take the next question also?
Okay.
Okay, so it goes here for you.
To perform an elective lower segment cesarean section, the obstetrician makes a transverse suprapubic incision. Which of the following abdominal wall layer will not be encountered transected during the section? What is this mean? Anterior rectus sheath, posterior rectus sheath, rectus abdominis muscle, skin and subcutaneous tissue, transversalis fascia, and parietal peritoneum. Well, transversalis fascia and parietal peritoneum may be the answer. Anterior rectus
Why
sheath को तो हम
maybe?
To perform an elective cesarean section, the obstetrician makes a transverse suprapubic incision. Which of the following abdominal wall will not be encountered transected during this incision? What does this mean? They are asking about which will not be transected during the incision.
Yes.
So interior rectus sheath will
They
be.
are saying about transverse suprapubic incision, not the lower segment cesarean section.
Oh,
incision.
okay. So interior rectus sheath will be cut, and posterior rectus sheath will be cut. Rectus abdominis muscle will be cut. We don't cut them, we separate them. Skin and subcutaneous tissue is cut. Transversalis fascia and parietal peritoneum. I think E is the option.
Okay. Can we have Rubina here?
Yeah, it can be B, posterior rectus sheath maybe.
Okay, you are in the exam. You cannot mark 2 options, Sana. You'll have to
Yes.
mark only one
Yes,
option.
I know.
So please choose only
So I'm
one
doubting
for us.
about the transversalis fascia because I don't remember that we do this. And posterior rectus sheath also.
Yeah, so you're confused. Okay, we'll take help from someone else. Okay, we can have Fiva, would you like to answer?
Ma'am, I think it is the posterior rectus sheath.
Okay, why do you think it's posterior rectus sheath?
No, I was just recalling cesarean section.
Yes.
We do the skin subcute. We go through the anterior rectus sheath. The posterior, no. Rectus abdominis muscle we separate. We go to the parietal peritoneum transversalis. Yes, I think. I'm not really, but I think it is posterior rectus sheath.
Yes, excellent. Yeah, you are right. And even Sana was confused, but she was also right that posterior rectus sheath, because posterior rectus sheath is not present below the arcuate line.
Yes, you are right.
In the in the previous question we just discussed this, that posterior rectus sheath is absent below the arcuate line.
Okay, yeah, right.
So this question is the turn towards the right.
Yeah. Okay.
Who is going to take the next one? Noorpur, can we have you here on the board to answer our question, please?
Yes, ma'am.
Okay.
So,
yeah, next question. Okay, your question goes here. This one is the question for you.
Which of the following is not the content and composition of rectus sheath? 1. External oblique, 2. Internal oblique, 3. Transverse abdominis, iliac is 4th. Ma'am, fourth.
You're going to tell us?
Fourth, ma'am, iliacus.
Yes, iliacus is not a part. Is not a part. The content of rectus sheath. Excellent.
Thank
Okay.
you, ma'am.
So go for the next question also.
Okay. Nerve passing through rectus sheath. A. Subcostal nerves. B. Ilio-hypogastric nerves. C. 10 lower costal nerves. D. 5 lower costal nerves. Ma'am, A and D. E.
Only NG?
Oh, ma'am. Lower
Yes.
10 I'm not sure.
Yeah, no, you are right. I'm trying to confuse you.
Okay, ma'am. A and D.
Yeah, A and D. 5 intercostal nerves and subcostal nerves. So it becomes A and D. Option E is the correct answer. Yes, you're right. Excellent.
Thank you.
Yeah, no, of course.
Thank you.
Yes, Fiba. Dr. iPhone. Yeah, you all are right in the chat box. Okay, who's going to take the next one? Next question. Seher, would you like to try? Rubina, would you like to try? Tahira, would you like to?
Yes, ma'am, I will try.
Oh, okay, yeah, Rubina, go ahead, please. Okay. Yes.
How many tendinous insertions are there in the rectus abdominis muscle? A2, B3, C4, D5, 7, E7. Ma'am, 3 tendinous insertions are above the umbilicus and 1 is below the umbilicus. So 4, C option.
C option? Anyone else? If I give you one more chance to think?
Ma'am, 3 are above the umbilicus. 1 is below the umbilicus, ma'am. I remember 4.
Okay, I'll take you back to that slide for the rectus abdominis muscle. Okay, so you just okay, rectus abdominis muscle. Now tell us how many insertions are there, tendinous insertions are there for rectus abdominis muscle? 3, 4, 5, 7. Rubina, we all are waiting for your answer. Rubina, are you there?
Yes, ma'am.
Yes. Yes. So tell us. Look, what it says, the cartilages of ribs 5, 6, and 7.
Up to 7.
So how many
Yes,
it becomes?
ma'am.
How many tendons? 5, 6, 7, 3. Yes.
Yes,
So
ma'am.
now exactly,
Yes,
you're very right. It becomes 3. 3
yes,
insertions,
ma'am.
3 tendinous insertions for rectus abdominis muscle. Okay. So you will try for the next question also?
Yes, ma'am.
Yeah, okay.
Structures not involved in lower abdominal cesarean section but involved in supraumbilical. Anterior rectus sheath, posterior rectus sheath, both of the above, none of the above.
We just discussed this question
Ma'am,
now.
B posterior
Yes,
rectus
this is the
sheath. B.
difference. Yes, excellent, Rubina. Yeah. Clapping for all of you.
Thank you.
Fiba, Sana, Rubina. I'm so happy that you're all learning actively.
Thank you, ma'am.
No problem, dear. So, Sansita, would you like to try the next question?
Yeah, ma'am.
Okay, so it goes for you.
Regarding the inguinal canal, it is 4 centimeter in length.
Excellent. You don't even need to read the options. You're so perfect. Mashallah.
Yeah.
Okay, so next question goes for you.
Which of the following nerve pass through the inguinal canal? It's ilioinguinal nerve.
Inguinal nerve. Yeah, a very simple question. Okay,
Yeah,
so would
ma'am.
you like to take the next question also?
Yeah, sure, ma'am. No problem.
Yeah. Okay.
The inguinal canal transfers the round ligament and which important nerve? Again, ilioinguinal nerve.
Excellent. Yeah.
Yeah.
Excellent. Okay, who's going to take the next one? Farah, would you like to give a try? Anyone volunteer can try, please. Andrea, would you like to try? We have Tahira here. We have so many participants. Okay, Fiba, would you like to try again?
No problem, ma'am.
Yeah, okay. So it goes for you.
Which of the following structure does not pass through the female inguinal? Spermatic cord. Option
It's spermatic cord. Yeah. Okay. So, okay, now.
Okay, this structure enters inguinal canal and is identified easily at laparoscopy. Enters the inguinal canal. It's the inguinal canal round ligament.
Yes, inguinal canal. It laparoscopy, you can easily visible the round ligament. The round ligament is really excellent.
Okay, ma'am.
Okay, would you like to take the next one?
Yeah, no problem, ma'am.
Okay. No. Okay.
Femoral triangle is medially bordered by medial, right? Lateral. Wait, I'll tell you.
Yeah, take your time. We have the mnemonic. Think of the mnemonic and
sail,
give answer.
sail.
Take your time.
Sail, right? Adductor, lateral, medial, right? So it should be adductor longus.
Excellent. Yeah, it's adductor longus.
Yeah.
Thank you so much, Fiba.
You're welcome, ma'am.
Okay. Rubina, would you like to try the next one?
Yes, ma'am.
Okay, sure. Go ahead, please.
An 82-year-old woman attended her general practitioner surgery complaining of a painful lump in the groin. Which of the following does not form a boundary of the femoral triangle? Adductor longus muscle, inguinal ligament, obturator internus, pectineus, sartorius. Ma'am, C, obturator internus.
Yes, because the obturator internus does not form the part of a triangle.
Yes,
excellent.
Because lateral boundaries formed by sartorius, medially adductor longus, and then pectineus and inguinal ligament form the base.
Yeah, excellent. Yes, Noorpur and Fiba, you are also correct in the chat box. Claps for all of you. Okay, so will you take the next one?
Yes, ma'am.
Okay. Oh, okay. I'm so sorry. The questions are ending here.
Okay, ma'am.
Okay. So any questions before we move ahead? I'm so sorry, Sana. All the questions are over, but definitely by night I'll be posting more questions in the group. So I want all of you to be actively answering those questions.
Well, I wanted to know from where should we study anatomy and MCQs as well. Also, I wanted to know, you were supposed to repeat the lecture, so you didn't repeat the lecture of yesterday.
Okay.
And no recording available of that lecture.
Okay. Okay, no problem. I'm going to repeat it now. No problem. I have the lecture with me, just in here with me. So I'm going to repeat it. If there was any problem for yesterday's, yeah, I know the recording was not done properly. I'm just going to start it with again. Okay. And yes, specifically for anatomy, the best book that you are going through is going to be your Oxford revision note. Everything is there in that book. But if you need that, you want to see the diagrams for your memory or for just to clear your concept again, so the Snell is the best book for that, just for the diagrams of this. Otherwise, all the books are really very, Oxford revision notes is more than sufficient because it covers every question from there.
Ma'am, today's recording will also be available because I missed in first 30 minutes.
Yes, yes. Today's recording will also be available.
Yeah, thank you, ma'am.
Yeah, no problem. And yes, Sanaya, definitely. I'm going to tell you all the books that are important for solving anatomy, not only for anatomy, but for all the modules. And I'll be posting questions daily in the group so that you all answer those questions in the group for me.
Ma'am, will we have lecture tomorrow also?
Okay, I have made a schedule. Shall we go to the schedule first? No.
Yeah, ma'am.
Okay. I'm unable to share my screen. The screen is not being shared. Is my screen visible?
No, ma'am.
Okay, let's give me. What has happened to the screen? Certain. Is the screen visible now?
Still no, ma'am.
No? Okay.
Maybe, ma'am, you can post it in the group.
Gee, doctor. Yeah, just I'm just adjusting the setting. The screen will be visible in a second.
Dr. Aqsa, you can share the screen now.
Okay, thank you so much. Yeah, so for today and tomorrow we have done our 2 sessions, and the next session will be on 21st of September, then 22nd of September, and I've also decided the topics for the sessions. And then we are going to have it on 28th, 29th, and then on 10th of October. And then the frequent sessions, I'll be telling you all the schedule once I just made it out of my free time. So I'll just share that also with you.
Okay, ma'am. Thank you.
Okay, no problem, dear. Okay, so yeah, so basically what this exam is, this MRCOG, it's a membership of the Royal College of Obstetric and Gynecologists. So it's an international degree which is recognized or a career progressing in OBGY. It's a key part for the UK training program, and all the trainings have to pass this exam. And MRCOG Part 1 is not just the completion of your degree. You will have to go for Part 2 and also for Part 3 as well. The Part 3 is the Viva, and Part 2 is the theory part of the guidelines that we have. Now, how do we apply for this exam? First, you have to log in onto the website, that is www.rcog.org.uk members registration. So once you log onto this website, you will have to fill your name and the email address. And once you submit that email address and name, they will send you a code or a college number to you. That college number, you will be given an eligibility form to fill the exam. For the exam. So in that eligibility form, what you have to do, you have to insert that code or the college number, and you will have to give the proof of your medical degree or the registration certificate that you have. You can submit either the photocopy or the scan copy for that. Both are accepted. Once you submit that, then, and it has to be approved by the RCOG, that you're eligible for, your eligibility criteria has been approved by the RCOG college. Once they do that for you, then you will be able to apply for the exam. Now the date for this eligibility form has already gone, that it was Thursday, 27th of August, 2020. And the application for the forms, they're opening day after tomorrow, that is 17th of September, Thursday. And they will close after 1 month, that is on Thursday, 22nd of October, 2020. Now the exam will be in 2 ways. You like usually for Pakistan's and Indian students who are giving the exam, they fall in the category of band B. So the fees for band B is £475. So if you go onto the website, you can always find which country you belong to. So depending on your country, depending on your band, you will have to pay the fee for that exam. And if anyone who has appeared for the exam before and is resitting for the exam again, or everything has been done for that, the eligibility form has been filled, you just need to go to the website, pay your fee, and just your form is ready to be submitted for the next exam. And if you do have any problems with submitting the form, please do ask us. We are there to help you always. Now, what is this exam format? So this exam, like other exams like FCPS or MCPS exam, it also has 2 paper. Paper 1, 50%, and paper 2 also accounts for 50%. Paper 1 is for 2.5 hours. After that, there will be break of 1 hour. And after that, paper 2 will start. That is 2.5 hours or 150 minutes for both of the paper. And in both of the paper, there will be 100 single best answers. And now the exam will be computer based. So you will have to go to the center. The computer screen will be there in front of you and you have to solve it. So after this, once we have covered whole of the anatomy module, I'll be taking the same exam in the form like you're giving it in the RCOG, so that you have to have an idea that how the exam pattern looks like, so that at the end you don't have any anxieties or worries for your exam. Okay, and then am I clear till here? Any questions so far?
No, ma'am.
Okay, thank you so much. No, for acknowledging that. So now coming to the syllabus, what is the syllabus for this exam? From where to study anatomy, from where to study physio, pathology, biochemistry, the biostats, which everyone feels that it's a very big panic attack or a yoke what this biostats is, but definitely will make it very easier and simplified for you all. So for paper 1, we have anatomy, the most important module of paper 1. And the major questions come from this anatomy. That is why I have decided to discuss whole of the anatomy in these sessions. Then next, we have embryology, we have genetics, physiology, endocrinology, biochemistry, and biostats. So in paper 1, the most important part is the anatomy, then endocrinology, and then few questions, and then only 5 to 6 questions they come from biostats. But we don't want to miss any chance to lose any question. We have to answer 100% questions, because some of the questions we don't know, that we may be, because of our anxiety, we may be very difficult, or in a stressful situation we may do it wrong. So we have to do it our 100% input. And for paper 2, we have pharmacology, pathology, microbiology, immunology, biophysics, clinical management, and data interpretation. So for paper 2, the most important is pathology, and then we have this pharmacology. These are the two most important for paper 2 modules. And then the clinical management and data interpretation. From these, around 10 questions they come from these two module, clinical management and data interpretation. And definitely we'll be discussing in this the ABGs, how to answer a report of either electrolyte imbalance, or if there's a report of full blood count, how do we answer those questions? The tips and tricks we are going to discuss in those modules. So it's just a picture form of that we have the same subjects for paper 1 and paper 2. Now, how to prepare for this exam? Not only for anatomy, but for any module of this exam, your main book will be Oxford Revision Notes, and the another book will be Essential Revision Guide. If you have any queries with these books, then we are going to take the reference from Green Top Guideline and NICE Guidelines. But sometimes what happened, this Oxford Revision Note, it was published in 2011. So some of the percentages, they're older in this book, like percentage of preeclampsia, percentage of hypertension in pregnancy, gestational hypertension, GDM. These percentages, they are a bit old. So for that, we will take the help from the guidelines just to update our knowledge. Now, after reading every whatever theory part you read, either you read anatomy, either you read physiology, pathology, microbiology, genetics, the most important thing is that you need to solve the single best answer, because the key to success is to practice, revise again and again, because once it sets into your mind, at the back of your mind, it will not be erased. So revision and practicing is the successful key for this exam. And it will also help to improve your concepts, like some of the things that you were not clear, they will become more clear once you solve the questions. So this is Oxford Revision Notebook for MRCOG Part 1, and this is the Essential Revision Guide. So we have the PDF available. We have the hard copies also available. So you can easily find these books in Pakistan, especially in Karachi. They are available at Urdu Bazaar opposite Dow Medical College. These books are easily available over there. If you find it easy to read it in the computer or the PDF form, it's okay. If not, then hard copies are also easily available in the market. Now, for any module, like as you were asking which books to solve for anatomy. So we have Andrew Caesar, we have Catherine, we have Ankush Raut. These are the books, practicing books for single best answers that you are going to solve. And along with that, we have question banks from past MRCOG. We have question bank from Strategy. We have on examination and busy SPR. So daily, I am going to post the questions, but I want all of you to post only 5 questions per day, so that we all can discuss our confusions and clear our concept. And by then, we will have one big folder for anatomy, one big folder for physiology, so that it is easier for you to revise in the end the important questions and to practice for yourself also. So why the questions are important? The SPS, they're important because you will have the ability to get on the catch points in the SPS, that which thing is most important or most likely, which is the least important thing or the least likely. All of the following options are true, except, or all of the following options are true about rectus sheath, except, or any differentiating points from the disease, like for diabetes, for hypertension. We have some key points that we need to know. Definitely we'll be discussing our modules that. So what do I always say? That whenever we hear, we forget. Whenever we see the things, we remember. And once we do it, we will understand it. So the more you practice, the more you will become skilled. And trust me, if I can do this exam, you all can do this exam. It's just you need a bit of hard work and a consistency towards this exam. It's a doable exam. Every one of all of us can do it. We all need to get a degree, and we need to all of you to celebrate. We want all of us to be celebrating your success together for clearing part 1 and moving towards the next journey of part 2. So we need to learn, we need to study, we need to practice, we need to skills by solving more of the questions, and we need to work hard for that. At least if we give, because all of you, majority of all, you will be working. So if you are studying very smartly, only 3 to 4 hours per day, but in the last month of the exam or last 15 days, if you give 10 to 12 hours, it will be more than sufficient for exam. Trust me, because this exam is really doable. Everything is related to obs and gynae, the physiology, the pathology, the anatomy. Everything is only related to OBGYN. Nothing is outside this field. In the exam, they make sure it's an international exam, and they make sure everything is limited to the course. Nothing is outside the course. If I can do it, you all can do it. Trust me. So any questions till now?
Ma'am, is part 2 really difficult? I've heard that it's very difficult. Part 1 is doable, but part 2 is difficult.
No, what I would tell you, I'll tell you, part 2 is difficult, but it's not that difficult that you can't do it. Trust me, you can do it. I was also the one who used to think like this, but when I gave for my exam, I only took 3 months of my preparation after my FCPS completion. I just took 3 months. I just sat at my home and just did everything, and it was doable.
And ma'am, with work and baby, part 2, and is it necessary, ma'am, that we need to work in UK to clear part 2 and part 3, or
No.
not working in UK we can do from like other countries also?
Because I myself is an example for all of you. I did my part 1 from Pakistan. I did from my part 2 also, but for part 3, definitely the exam is only here in UK, or we can give in other countries like India, depending on the center. But it's not necessary that you will be working in UK. The training is same everywhere. Just the method is a bit different, like sterilization is more, because our countries, they're a little bit low in economics. But for these countries, these are just the normal things. But otherwise, the exam is really doable.
Thank you, ma'am. Thank you so
No
much.
problem. No problem. Any questions more? So it's a promise you'll be posting the questions daily, all of you? Only 5 questions per day, or only 3 questions, minimum of 3, maximum of 5 questions per day, from the topics that we have covered so far. If you can take, each of you, if you can take one of the books, like Andrew Sizer, Catherine, Ankush, only 3 questions from that book every day.
Ma'am, Andrew has true and false also. These days that has those patterns don't come, no?
No, those patterns don't come now. It was an older pattern.
Okay, ma'am.
But it just can help you in solving the questions, just a practice.
Okay, ma'am. Yeah, thank you.
So I'll be posting the questions, and I want all of you to post the questions daily, at least minimum of 3 and maximum of 5 questions, if you all can do it. Only related to anatomy, or specifically related to anterior abdominal wall, inguinal ring, femoral triangle, just this much. And definitely, inshallah, we'll try to upload this video also today for you. Any further questions before we end?
No, ma'am. Thank you so much.
All right. No problem, Nupur. Thank you so much, everyone. Have a good night. Take care. Bye-bye.
Good night, ma'am.
Good night.